Since this is an emerging field of OT, we conducted interviews to learn more information.
We had the opportunity to interview Dr. Stewart, an OT in this field, as well as Matthew Val, a social worker who works with this population.
The reassignment kind of reinforces the gender binary, right? That you're moving from one gender to another. And that's not always everyone's experience, especially for our patients who identify as non-binary or gender expansive or gender diverse. The experience is not necessarily I'm moving from man to woman or woman to man, but I may be somewhere off the binary altogether.
Some common surgical terms that you're going to be hearing throughout this presentation include metoidioplasty, phalloplasty, and vaginoplasty. Metoidioplasty is the creation of a penis from an enlarged clitoris. Phalloplasty is the creation of a penis from your arm or leg skin, and vaginoplasty is the construction of a vagina.
The Rush Gender Affirmation Center resumed bottom surgeries 2 weeks ago, with Dr. Schechter being the only plastic surgeon who completes the surgery at Rush Hospital. Outside of Rush, there are only 3 plastic surgeons in Illinois who perform bottom surgeries, which greatly limits patients' access to care.
It's been a while since we've been able to do the bottom surgeries, at least, so phalloplasty and vaginoplasty and metoidioplasty. So that's what's restarting. In the meantime, we have still been able to offer top surgery and facial feminization surgery and vocal surgeries.
We created protocols based off of their feedback on what patients were not allowed to do, and from there we created a whole educational packet and reviewed how to get dressed after surgery, how to get in and out of bed safely, how to toilet, how to sit for prolonged periods of time after genital surgery. And when patients were undergoing phalloplasty and metoidioplasty, they had radial forearm free flap skin grafts on their arms. And so there was a whole other very extensive protocol for rehabilitation of the arm after surgery. We didn't even realize that bending forward hurt because it puts more pressure on the genital area. And so we told the surgeons hey, putting on socks and shoes is very painful for these patients, for a month after surgery. This is what we recommend. This is what we think this should be, blah, blah, blah. And they were like, yep, that makes sense. Let's do that. It was getting dressed and toileting and bathing. Those were the big ADLs that we had to review with them on how to do them safely so they don't get an infection and they don't mess up their surgery.
I think where it comes into play with bottom surgery is especially around the vaginoplasties. There's often some pelvic floor work that has to be done. And also sometimes some work with the dilators, because you do, after a vaginoplasty, you do have to dilate for the rest of your life. And so it's very intensive at the beginning, and then it becomes less and less frequent as you get further away from the surgery. But at the beginning, I think there's some work around how to use the dilator. Outpatient opportunities for OT as well, though. Dr. Schechter is going to be hiring a full-time physical therapist for his clinic. And I can see there being so many opportunities for OT in that space as well. Yeah. So barriers to accessing care, we just don't have enough providers. And I always use providers very broadly to include all of us and kind of the allied professionals they used to call it, right? There aren't enough providers with even the kind of cultural competence to provide affirming and competent care to folks. And so this needs to be kind of more baked into medical education and healthcare education in general. And then some of the more concrete barriers, it's only recently that insurance companies have started to cover things like surgery and hormone therapy. But there needs to be ongoing advocacy around that coverage, especially for Medicaid, because that's very new in Illinois that Medicaid is paying for it. There's still a lot of confusion with the different Medicaid HMOs about what that entails. And then WPATH, which is the World Professional Association for Transgender Health, they're the governing body that kind of sets the standards for providing trans care or gender affirming care. And they're working on revising their guidelines right now, but they still have a lot of unnecessary, in my opinion, unnecessary barriers. For bottom surgery, you have to get 1 physician letter and 2 mental health letters just to even have access to surgery. Confirming the diagnosis of gender dysphoria and also doing just a mental health evaluation to make sure that they can make an informed and competent decision. And, in my mind, that's just provider anxiety about, what if the patient regrets the surgery? The rate of regret is extremely low in this population. And so if you're a trans woman and you're going to get breast augmentation, you have to go through a psych eval, essentially. If you're a cisgender woman going for some kind of breast reconstruction, whether because of breast cancer treatment or for cosmetic reasons, no one asks any questions, right? And as a team, me and the patient navigators we would do kind of what we were calling a pre-surgical assessment. So like a psychosocial assessment, trying to figure out what the non-surgical needs were. Like, do you have stable housing? Do you have a place to recover? Do you have the support that you need to recover? Do you have any insurance issues? So anything that could affect the outcomes of the surgery that were kind of non-medical, we would assess. For example, from a mental health perspective, is that there have been occupational impairments. That's part of the diagnosis of gender dysphoria. That you're not able to do what you need and want to do on a daily basis because of this diagnosis, and that this surgery is going to help alleviate some of those impairments. Speech and language pathology, because there's a subspecialization under there for voice therapy for folks who want to modulate their voice, is especially for trans feminine folks. Testosterone does a pretty good job at lowering people's voices if they're on that hormone therapy, but estrogen does not do very much to elevate the pitch of your voice, and so a lot of folks will access voice therapy. And it's a prerequisite to getting vocal surgeries that you need to try the voice therapy first. So speech and language pathology is another important one. Dermatology or even an esthetician, super important, because laser or hair removal or electrolysis is required prior to bottom surgeries. And it's very expensive and hard to access, hard to find competent people. And so we're working on trying to get our own laser machine.
There needs to be more research, education, and knowledge incorporated into all healthcare professional curriculums regarding gender affirmation surgeries. The World Association of Transgender Health is the governing body of the gender affirming process. However, in their post-operative standards of care, they do not list occupational therapy as a recommended service after surgery, which is something we should work to change. It is our job to advocate for our field in order to better the lives of individuals undergoing gender-affirming surgeries.